Hello friends, I am Dr. Anshul Garg. Today I am going to present an interesting and learning episode on antihistamines, a very important topic from point of view of pharmacology and medicinal chemistry. Expert of today's topic is Pradeep Ganpat Nirbhavne, PhD scholar at Punjab University, Chandigarh. For ease to understand the topic, it has been divided into 5 modules. First module is Introduction of Antihistamines and Cromolyn Sodium. Module 2, Classification of H1 receptor antagonists. Module 3, Structure Activity Relationship of H1 antihistamines and its pharmacological effects. Module 4, Pharmacokinetics, Side Effects, some important synthesis. Module 5, Clinical Classifications, Dosage and Preparations of Antihistamines. Module 1, Introduction of Antihistamines and Cromolyn Sodium. Now let's understand what is antihistamines. Antihistamines are widely used in the palliative treatment in allergic conditions like hay fever, urticaria, some forms of pruritus, rhinitis, conjunctivitis, nasal discharge, mild asthma, etc. A few antihistamines possess potent antiemetic action and hence are frequently employed in the prevention and treatment of irradiation sickness, motion sickness such as in ARC road, nausea in pregnancy and postoperative vomiting. In general, the most common side effect of antihistamines is sedation, which may be followed by drowsiness, impaired alertness and retarded ability to perform jobs which need high precision and concentration. The discovery of the bronchodilating activity of the natural product khelin led to the development of the bis chromones as compounds that stabilize mast cells and inhibit the release of histamine and other mediators of inflammation. The first therapeutically significant member of this class was cromolyn sodium. Cromolyn sodium. Cromolyn sodium in US pharmacopoeia is disodium 1,3-bis 2-carboxychromone 5-iloxy 2-hydroxypropane. It is a hygroscopic white hydrated crystalline powder that is soluble in water in the ratio 1:10. The pKa of cromolyn is 2.0. It is available as a solution for a nebulizer, an aerosol spray, a nasal solution, an ophthalmic solution and an oral concentrate. Nebulized and aerosol cromolyn is used for prophylactic management of bronchial asthma and prevention of exercise-induced bronchospasm. Cromolyn nasal solution is used for the prevention and treatment of allergic rhinitis and oral concentrate is used to treat the histaminic symptoms of mastocytosis, which includes diarrhea, flushing, headaches, vomiting, urticaria, abdominal pain, nausea and itching. In the treatment of asthma, cromolyn efficacy is manifested by decreased severity of clinical symptoms or need for concomitant therapy or both. Long-term use is justified if the drug significantly reduces the severity of asthma symptoms or permits a significant reduction in or elimination of steroid dosage or improves management of those who have intolerable side effects to symptomimetic agents or methylxanthines. For cromolyn to be effective, it must be administered at least 30 minutes prior to antigen challenge and administered at regular intervals. Overuse of cromolyn results in tolerance. Usual adult dose of antihistamines in nebulizer solution is 20 mg inhaled QID and in aerosol form is 2 metered sprays inhaled QID. Now, module 2, classification of antihistamines. Now, as you understand briefly about the term antihistamines and its properties, let's go deeply into these drugs. First, let's see about the different types of antihistamines. The commonly used antihistamines may be classified on the basis of their chemical structures, and these all are of the type histamine H1 receptor antagonists. They are histamine H1 receptor antagonists are broadly categorized into 7 classes. First is amino alkyl ethers. Its examples are diphenhydramine hydrochloride, bromodiphenhydramine hydrochloride, diamine hydrinate, doxylamine succinate, diphenylpyrrolene hydrochloride. Second is ethylene diamines. Its examples are mepyramine maleate, triphenamine hydrochloride, thionzylamine hydrochloride, zolamine hydrochloride. Third is thiophene derivatives. Its examples are methapyrrolene hydrochloride, methaphenylene hydrochloride, phenyldiamine hydrochloride and chlorothiene citrate. Fourth is cyclic basic chain analogues. They are of basic three types. First is imidazolene derivatives. Its example is antazolene hydrochloride. Second is piperazine derivatives. Its example is cyclizine hydrochloride, chlorocyclizine hydrochloride, meclizine hydrochloride, buclizine hydrochloride. And third is piperidine derivatives. Its example is phenylidine tartrate. Fifth is phenothiazine derivatives. Promethazine hydrochloride, promethazine thiochelate, trimeprazine tartrate, metdiazine hydrochloride. Sixth is second generation non-sedating antihistamines. Its examples are terfenadine, astemizole, loratadine, acrivestin. And seventh is miscellaneous agents. Its examples are phenendiamine tartrate, triprolidine hydrochloride, chlorpheniramine maleate and cyproheptadine hydrochloride. Now let us start with module 3, which includes structure activity relationship, that is SAR, of H1 antihistamines and its pharmacological effects. Now start with structure activity relationship. The H1 antagonists are now commonly subdivided into two broad groups: first generation or classical antihistamines and second generation or non-sedating antihistamines, based primarily on their general pharmacological profiles. The basic structural requirements for H1 receptor antagonism have been identified as those shown in figure shown on the screen. Shown is general antihistamine structure. In this structure, AR is aryl group including phenyl, substituted phenyl and heteroaryl groups such as 2-pyridyl. AR apostrophe is a second aryl or aryl methyl group. X is a connecting atom of O, C or N or CST whole to the power N. Usually represents a carbon chain, usually ethyl, and NRR represents a basic terminal amine function. As you can see, the general structure of antihistamines contains various groups at various positions. Let's see about the structural development of the active moieties of this class by studying the effect of different groups at different positions at this structure. This diaryl substitution pattern is present in both the first and second generation antihistamines and is essential for significant H1 receptor affinity. Furthermore, several SAR studies suggest that the two aryl moieties must be able to adopt a non-coplanar conformation relative to each other from optimal interaction with the H1 receptor. The two aromatic systems may be linked, as in the tricyclic antihistamines, which includes phenothiazines, dibenzocycloheptanes and heptanes. But again, they must be non-coplanar for effective receptor interaction. Most H1 antagonists contain substituents in one of the aryl rings, usually benzene, and these influence antihistamine potency as well as biodisposition. All the available H1 receptor antagonists are reversible competitive inhibitors of the interaction of histamine with H1 receptors. Like histamine, many H1 antagonists contain a substituted ethylamine moiety. Unlike histamine, which has a primary amino group and a single aromatic ring, most H1 antagonists have a tertiary amino group linked by a 2 or 3 atom chain to two aromatic substituents. Example includes diphenhydramine. Diphenhydramine, in many of the first generation or classical antihistamines, the terminal nitrogen atom is a simple dimethyl amino moiety. The amine may also be part of a heterocyclic structure. However, as illustrated by the piperazines, some propylamines such as pyrrolidines and piperidines, some phenothiazines, the dibenzocycloheptanes and the second generation antihistamines. In all cases, the amino moiety is basic, with pKa's ranging from 8.5 to 10 and thus is presumed to be protonated when bound on the receptor. The moiety is also important in the development of stable solid dosage forms through salt formation. The carbon chain of typical H1 antagonists consists of 2 or 3 atoms. As a result, the distance between the central point of the diaryl ring system and the terminal nitrogen atom in the extended conformation of these compounds ranges from 5 to 6 angstrom. A similar distance between these key moieties is observed for those antihistamines with less conformational freedom. In some series, branching of the carbon chain results in reduced antihistaminic activity. There are exceptions, however, as evidenced by promethazine, which has greater activity than its non-branched counterpart. When the carbon adjacent to the terminal nitrogen atom is branched, the possibility of asymmetry exists. The X connecting moiety of typical H1 antagonists may be a saturated carbon oxygen moiety or simply a carbon or nitrogen atom. This group, along with the carbon chain, appears to serve primarily as a spacer group for the key pharmacophoric moieties. Many antihistamines containing a carbon atom in the connecting moiety are chiral and exhibit stereoselective receptor binding. For example, in the phenyramine series and carbinoxamine, this atom is chiral, and in vitro analysis indicate that enantiomers with the S configuration have higher H1 receptor affinity. Generally, the first and second generation antihistamines are substantially more lipophilic than the endogenous agonist histamine or the H2 antagonist. This lipophilicity difference results primarily from the presence of the two aryl rings and the substituted amino moieties, and thus may simply reflect the different structural requirements for antagonist versus agonist action H1 receptor. Pharmacological effects. Now, they are mostly opposite to the effects produced by the histamine. They are stated in different sections, such as first is smooth muscle relaxants. Within the vascular tree, the H1 antagonists inhibit both the vasoconstrictor effects of histamine and to a degree the more rapid vasodilator effects that are mediated by activation of H1 receptors on endothelial cells, which includes synthesis or release of NO and other mediators. Second effect is on capillary permeability. H1 antagonists strongly block the increased capillary permeability and formation of edema and wheal brought about by histamine. Third effect is flare and itch. H1 antagonists suppress both the flare component of the triple response and the itching caused by intradermal injection of histamine. Fourth effect is immediate hypersensitivity reactions. During hypersensitivity reactions, histamine is one of the many potent autocoids released, and its relative contribution to the ensuing symptoms varies widely with species and tissue. The protection afforded by histamine antagonists thus also varies accordingly. Fifth effect is on CNS, that is central nervous system. The first generation H1 antagonists can both stimulate and depress the CNS. Stimulation occasionally is encountered in patients given conventional doses who become restless, nervous and unable to sleep. Central excitation is a striking feature of overdose, which commonly results in convulsions, particularly in infants. Central depression, on the other hand, accompanies therapeutic doses of the older H1 antagonists. Diminished alertness, slowed reaction times and somnolence are common manifestations. Some of the H1 antagonists are more likely to depress the CNS than others, and patients vary in their susceptibility and responses to individual drugs. The ethanol amines, example is diphenhydramine, are particularly prone to cause sedation and are used as over-the-counter OTC somnolents. Indeed, these drugs cannot be tolerated or used safely by many patients unless given only at bedtime. Patients may experience an antihistamine hangover in the morning, resulting in sedation with or without psychomotor impairment. The second generation, that is non-sedating H1 antagonists, examples are loratadine, cetirizine and fexofenadine, are largely excluded from the brain when given in therapeutic doses because they do not cross the blood-brain barrier. An interesting and useful property of certain H1 antagonists is the capacity to counter motion sickness. This effect was first observed with diamenhydrinate and subsequently with diphenhydramine, the active moiety of diamenhydrinate, various piperazine derivatives and promethazine. The sixth effect is anticholinergic effects. Many of the first generation H1 antagonists tend to inhibit responses to acetylcholine that are mediated by muscarinic receptors. These atropine-lined actions are sufficiently prominent in some of the drugs to be manifest during clinical usage. Promethazine has perhaps the strongest muscarinic blocking activity among these agents and is among the most effective of the H1 antagonists in combating motion sickness. The second generation H1 antagonists have no effect on muscarinic receptors. Anticholinergic action can be graded as high, low and minimum or absent. The molecules with high action are promethazine, diphenhydramine, dimenhydrinate, pheniramin, cyproheptadine. The molecules with low action are chlorpheniramine, hydroxyzine, triprolidine and cyclizine. The molecules with minimum or absent action are fexofenadine, estemizole, loratadine, cetirizine and mesolastine. Now let's start with module 4. It includes pharmacokinetics, side effects and some important synthesis. In pharmacokinetics, let's start with H1 antagonists which are eliminated more rapidly by children than by adults. That is, the activity of CYP1A2 and CYP3A4 appears to be greater in infants and children than in adults and more slowly in those with severe liver disease. H1 receptor antagonists also induce hepatic CYPs and thus may facilitate their own metabolism. Many H1 antihistamines are metabolized by CYPs. Thus, inhibitor of CYP activity such as macrolide antibiotics, its example is erythromycin, or imidazole antifungals, whose example is ketoconazole, can increase H1 antihistamine levels, leading to toxicity. Some newer antihistamines such as cetirizine, fexofenadine, levocabestine and acrevestine are not subject to these drug interactions. The second generation H1 antagonist loratadine is absorbed rapidly from the GI tract and metabolized in the liver to an active metabolite by hepatic CYPs. Consequently, metabolism of loratadine can be affected by other drugs that compete for metabolism by these enzymes. Now, let's understand side effects. The most frequent side effect in the first generation H1 antagonist is sedation. Although sedation may be a desirable adjunct in the treatment of some patients, it may interfere with the patient's daytime activities. Concurrent ingestion of alcohol or other CNS depressants produces an additive effect that impairs motor skills. Other untoward central actions include dizziness, tinnitus, lassitude, incoordination, fatigue, blurred vision, diplopia, euphoria, nervousness, insomnia and tremors. The next most frequent side effects involve the digestive tract and includes loss of appetite, nausea, vomiting, epigastric distress and constipation or diarrhea. Taking the drug with meals may reduce their incidence. H1 antagonists appear to increase appetite and cause weight gain in rare patients. Other side effects, apparently owing to the anti-muscarinic actions of some of the first generation H1 receptor antagonists, include dryness of the mouth and respiratory passages, sometimes inducing cough, urinary retention or frequency and dysuria. These effects are not observed with second generation H1 antagonists. Now let's study about other adverse effects which include drug allergy, which may develop when H1 antagonists are given orally but results more commonly from topical application. Allergic dermatitis is not uncommon. Other hypersensitivity reactions include drug fever and photosensitization. Hematological complications such as leukopenia, agranulocytosis and hemolytic anemia are very rare because H1 antihistamines cross the placenta. Caution may be used when they are taken by women who are or may become pregnant. Several antihistamines such as azelaistin, hydroxyzine and fexofenadine showed teratogenic effects in animal studies, whereas others which includes chlorpheniramine, diphenhydramine, cetirizine and loratadine did not. Antihistamines can be excreted in small amounts in breast milk, and first generation antihistamines taken by lactating mothers may cause symptoms in the nursing infant such as irritability, drowsiness or respiratory depression. Since H1 antagonists interfere with skin tests for allergy, they must be withdrawn well before such tests are performed. Now let's talk about synthesis of some antihistamines. Synthesis of these antihistamines are interesting and can be asked in exams for 2 or 3 marks. Most of these members contain aryl rings and substitution occurs on this ring. Now let's first talk about synthesis of diphenhydramine. The figure on the screen shows the synthesis of diphenhydramine. In it, diphenyl bromomethane is first prepared by the bromination of diphenyl methane in the presence of light. Subsequently, diphenhydramine base is obtained by heating diphenyl bromomethane, beta dimethyl aminoethanol and sodium carbonate in toluene. After distilling of toluene, the purified diphenhydramine is converted to the hydrochloride with hydrogen chloride. Now, let us start about synthesis of pyrilamine maleate. In the first step, 2,2-dimethylamino-ethyl-amino-pyridine is prepared by the condensation of 2-aminopyridine with 2-dimethyl-aminoethyl chloride with the elimination of a molecule of hydrogen chloride in the presence of sodamide. As shown on the figure in the screen, the resulting product on further condensation with p-methoxybenzyl chloride in the presence of sodamide yields the pyrilamine base, which on neutralization with malic acid gives rise to the desired product pyrilamine maleate. Now, let us talk about synthesis of promethazine. Phenothiazine is first prepared by fusing together diphenylamine and sulfur in the presence of iodine or aluminium trichloride. Promethazine base may be prepared by reacting the resulting phenothiazine with 1-chloro-2-dimethylamino-propane hydrochloride in the presence of sodamide and sodium hydroxide in xylene. The corresponding base is extracted, purified and converted to the hydrochloride. Now, let us start with module 5, which includes clinical classifications, dose and preparations of antihistamines. As shown in the figure, highly sedative drug includes diphenhydramine, whose dose is 25 to 50 mg and route is oral. Its preparations include Benadryl. Now, second drug is dimenhydrinate, which is given in dose of 25 to 50 mg and route is oral. Preparations include Dramamine. Third is promethazine, given in dose of 25 to 50 mg and route is oral or intramuscular. And the preparations include Phenergen. Now, the drug fourth is hydroxyzine, given in dose of 25 to 50 mg and route is oral. Preparations include Atarax. Now, in moderately sedative drug, first drug is Pheneramine, given in dose of 20 to 50 mg and route is oral or intramuscular. Preparations include Avil. Second is cyproheptadine, given in dose of 4 mg and route is oral. Its preparations include Practin, Ciplactin. Third drug is Meclizine, given in dose of 25 to 50 mg and route is oral. Preparations include Diligan. Fourth is Buclizine, given in dose of 25 to 50 mg and route is oral. Preparations include Longifene. Fifth is Cinnarizine, given in dose of 25 to 50 mg and route is oral. Preparations include Stegeran and Vertigon. Third class of drug is mild sedative drugs. First is chlorpheniramine, given in dose of 2 to 4 mg and route is oral or intramuscular. Preparations include Piriton and Cadistin. Second is dexchlorpheniramine, given in dose of 2 mg and route is oral. Preparations include Polaramine. Next is dimethindine, given in dose of 1 mg and route is oral. Preparations include Forestal. Next is triprolidine, given in dose of 2.5 to 5 mg and route is oral. Preparations include Actidil. Next is mebhydrolin, given in dose of 100 to 300 mg and route is oral. Preparations include Incidal. Next is cyclizine, given in dose of 50 mg, route is oral, and preparations include Marizine. Next is clemestin, given in dose of 1 to 2 mg and route is oral. Preparations include Tevagil. Fourth class of drug is second generation antihistamines. In this, first drug is fexofenadine, given in dose of 120 to 180 mg and the route is oral. Preparations include Allegra, Altiva and Fexo. Second is loratadine, given in dose of 10 mg and route is oral. Preparations include Lorfast, Loridine, Loramg. Next is cetirizine, given in dose of 10 mg and route is oral. Preparations include Cetzen, Zertin, etc. Next is levocetirizine, given in dose of 5 to 10 mg and route is oral. Preparations include Levosis, Levorid, Texine. Next is azelastine, given in dose of 4 mg and route is oral. In intranasal route, the dose is 0.28 mg. Preparations include Azep nasal spray. Next is mesolastin, given in dose of 10 mg, route is oral and preparations include alina. Next is Avastin, given in dose of 10 mg and route is oral, preparations include Avast. Next is Rupatadine, given in dose of 10 mg, route is oral and preparations include Rupahist. Now we have come to the end of the lecture. Now let's talk about the summary of the lecture. In the lecture, we have understood about the antihistamines. Antihistamines are a class of drugs which are widely used in treatment of allergic conditions. We have also discussed about its classification, structure-activity relationship of H1 antihistamines and its main pharmacological effects. Its effects are generally opposite to the effects produced by histamines. We have seen the pharmacokinetics of antihistamines and their major side effects, the most frequent side effect being sedation. We have also looked at synthesis of some of the antihistamines and also its clinical classification, which includes 4 classes. First is highly sedative, second is moderately sedative, and third is mild sedative antihistamines, and fourth is second generation histamines. So students, isn't it an interesting and informative topic about drugs used in treatment of allergy? I hope all of you enjoyed the topic. So it's time for test what you have understood from this topic. So have fun solving the test on this topic. Now allow me to take your leave. This is Dr. Anshul Garg signing off. Meet you in the next episode.